Test 1 2. Test 1 2.
Can't have that anymore. It's all or nothing.
Is the pharmacist on the CD?
No. Mike is coming. Oh, I forgot to turn mine.
By the way, I'm eating the sandwich.
Oh, great, Scott, gotta get this. Just get down, hey, just get down.
80 minutes.
It's great.
Will you tell Mike that he can come on over? Thanks. It's, I don't know.
Grab a few more flowers for that.
Well, he told me at 11 o'clock. And right before 11, he goes, I've got to leave because I'm going to see, and Dennis has gone to the bathroom, so can y'all watch Sprinter? I said, you don't have to leave yet. It's going to be at 11:30. He goes, "That's not okay for me." I said, well, I'll tell you when I leave, and then I'll go down to my job.
This is gonna be an issue.
Brad,
Yo.
you know, if she's doing this twice, you might need to stay in for both of them. I know your time of retention's not really kind of up to par.
That was
You got
low.
for box lunch and you have two.
There you go.
We'll make sure
At
you.
least make it worth my while.
Maybe I need to stay for both.
Right. Thank you for out of everybody in here picking on me.
You got singled out.
We prefer that you limit your sugar intake. That's really,
You're around, since I'm not like the all-time punching bag anymore, you kind of really did me up.
Sure will.
Thank you. I'll process it. Just waiting on that. Oh, see, that's why I said, can you press no?
Inspection meetings on next week.
That was what your plan was anyway.
Not going into inspection meetings regardless. Yeah.
about ready to get it started?
I am.
Just remember, just stay back there.
Yeah, Art just told me, he goes, I made this thing say.
All right, well, we're going to go ahead and get started. Everybody can come in and get settled, but welcome, and hope you enjoy your lunch. We appreciate them providing lunch for you today. My name's Heather Swindle, and I'm from the Emergency Department. I'm the system educator for the EDs for St. Vincent's. And our topic today is going to be adult codes. We're going to talk through our pharmacy aspects of adult codes in accordance with advanced cardiac life support that's put out by American Heart Association. So we're going to look at potential resuscitation drugs and drips that we use for the management of our adult patients. We're going to look at pharmacy practices in those resuscitation events. And we're going to look at evidence-based materials that give us our guidelines for the medicines that we give based on our rhythms. And we're going to talk through managing medication use process during adult codes. As y'all are familiar, we use American Heart Association as our standard for how we do our resuscitations every 5 years. They take plenty of research information and look at what's working well, what needs to be improved, what needs to be changed, and they publish the guidelines for resuscitation, CPR, every 5 years. So we're currently on 2015 guidelines. We'll get another guideline change in 2020, which usually takes about 2021 before we really get them into practice. So the information provided here and what we're currently using is on those 2015 guidelines. It is published through American Heart Association's ACLS. This is a required course for most of the nursing staff here in the hospital. It is a required course for the EDRNs, but this is what we use as the basis for our adult resuscitation. The ACLS does organize cardiac care into algorithms. We'll use the algorithms as a quick reference guide to know how to approach interventions when someone comes in an arrest state. It kind of is guided by either clinical presentation or rhythms that we're seeing during the resuscitation. They include bradycardia, tachycardia, also includes cardiac arrest. There are some algorithms for treatment of acute coronary syndromes and for stroke. We're going to focus just on the ones that have to do with cardiac rhythms. This is kind of our all-inclusive algorithm that we use. The picture that you're seeing kind of depicts how everything is devised around CPR. So if we're not doing good with our CPR, just our basic life support efforts, anything else that we're adding in as far as our resuscitation efforts are kind of going to be null and void if we're not keeping good BLS skills up and running. But we incorporate drug therapy, put down advanced airways, electrical therapy, and we focus in on reversible causes of why the patient may have arrested, but all of that is focused around good BLS skills. Your objectives as far as code medications and adjunctive therapies during CPR, we want to correct hypoxia. We want to restore circulation and blood pressure. We're going to promote optimal cardiac functioning, prevent or suppress any arrhythmias that we're seeing. We do want to relieve pain, fix our electrolyte abnormalities, correct acidosis, and treat any heart failure if we determine that's what's going on with the patient. The first algorithm that we'll look at is too slow. This is the overall algorithm that we use as our guide, and you'll notice you kind of follow your steps 1, 2, 3, and so on. And as we ask ourselves the questions that we're seeing in our clinical presentation with our patient, it'll guide us to which therapy to move to next. Some rhythms that we may see with bradycardia, the first one there you see is sinus bradycardia. The next one you see is a second-degree heart block. This is a type 1. There is also a second-degree type 2, and then a third-degree or a complete heart block. Any of these rhythms would be categorized into bradycardia rhythms. Typically what we see with bradycardia is a heart rate less than 50 and inadequate for the clinical condition. In other words, it's making them sick. I always try to tell our staff, look at the heart rate and then look at your patient. Is it causing symptoms for them? Because we get plenty of folks that come through the hospital, through the ER. 50 may be normal for them. Are they a conditioned athlete? Is it somebody that's on a lot of cardiac meds, maybe beta blockers? And we've got their heart rate, at 50 or maybe a little bit below, just therapeutically. So the whole key to bradycardia is the patient presenting with symptoms and a low heart rate. They may have altered mental status. They may be complaining of chest pain. They may be hypotensive. If they're not symptomatic, then you kind of just do the watch and wait. We leave them on a cardiac monitor. We usually draw some lab work. We do a 12-lead EKG and just kind of start to troubleshoot the what-ifs of could be going on with them. If they do have symptoms, then that's where we go back to that algorithm and start to guide our care. With bradycardia, the treatment, you'll notice oxygen is on there first. A lot of times folks that come in and are bradycardic, one of the first things that we see is hypoxia. Hypoxia and bradycardia tend to go hand in hand, so we'll usually start to look at airway and breathing and think about oxygenation on a first go-around. In the interim, after we have thought through oxygenation, you'll start to prepare a transcutaneous pacer, especially if you're seeing those rhythms that are heart blocks. Heart blocks indicate a fairly significant problem for the patient. If we can't come up with a why they are in a heart block, then we're probably looking at someone who is going for a transvenous pacer. So we'll usually get that on standby and ready. But we will start with our first drug of atropine. We'll start to give 0.5 milligrams of atropine up to 1 milligram of atropine. We'll give those IV push while we're waiting on our pacemaker to get ready. And if need be, you can give up to a total of 3 milligrams. So that would be our max on our atropine. Then we would start with our pacing. We also might consider a drip. If we've used all of our atropine, if the pacing is not always a viable option. If the patient's alert and oriented, there are not many people that are going to tolerate being paced because you're actually having to shock somebody to make the heartbeat. And it's about like having somebody put their finger in a light socket and hold it there. So I don't really get many takers for that one. So in lieu of that, we can use some drips. We can use an epinephrine drip or we can use a dopamine drip. We use 2 to 10 mics per minute on our epi drip. We use 2 to 20 mics per kilo per minute on our dopamine drip. The dopamine drip range changed from 2010 to 2015. Used to, the dopamine for bradycardia was just 2 to 10 mics, but they did increase the range to 20 mics in the 2015 guidelines. So we do get our pacer on. If they are unresponsive, we definitely pace them. But we also have to think through our whys, our contributing factors. Some folks just lose the intrinsic ability to naturally pace and beat the heart. Those are the folks that, again, wind up with a pacemaker. Some folks, we can usually trace it back. We get a lot of folks that come in, they may wake up in the morning and take their beta blocker. And then an hour later, you know what, I don't know if I took my heart pill, let me take my heart pill. And then before you know it, I've got some kind of beta blocker or calcium channel blocker overdose. So getting a history from patients and knowing what they're on, how much did you take, have you taken too much, can help give us clues, because a lot of folks can wind up with a heart block from overdosing themselves with their medications. We also can get a lot of cardiac problems with folks that have electrolyte imbalances. So some of our higher risk populations are diabetics. If they've missed dialysis, can tend to cause a lot of problems with potassium, and that can be a problematic as well. So with our atropine, our mechanism of action, it is a parasympathetic action. It blocks the vagus nerve to increase the heart rate. Again, we'll use it for heart rates less than 50 and they're symptomatic. Your dose again, 0.5 milligrams IV push, and then we repeat that up to 3 milligrams. So your pharmacodynamics, onset of action is immediate. Max effects in about 0.7 to 4 minutes. The half-life is really age dependent. It is excreted through the urine. You want to be real cautious when you're using your atropine if they are in a block because it can backfire on you a little bit, just as we would be cautious in someone that's having an MI. If they're having a heart attack and we give them atropine, they can go into VFib. So it's very cautious in those instances that we use our atropine. If I'm using dopamine for my bradycardia, it is an adrenergic agonist, an inotrope. It will cause a lot of arterial and venous constriction. It gives the renal arteries some constriction as well, but it'll increase the contractility of the heart. It gives me enough inotrope going positively to get a little heartbeat going. Onset of action is within 5 minutes. The duration is less than 10 minutes. The half-life is approximately 2 minutes, and that one's excreted through the urine as well. We do give this one IV only. Your concentrations for your dopamine may be 400 milligrams in 250 or 800 in 250. We usually do 2 to 20 mics per kilo per minute. It can be very caustic to the veins, so you're worried about extravasation on that. So we do want to make sure that we've got a good IV when we're starting to give that on patients. If we did an epi-drip, that does stimulate alpha and beta receptors. Again, stimulates cardiac muscle to get it beating for us. Onset of actions within 5 minutes. Half-life elimination is usually less than 5 and excreted through the urine as well. Our concentrations on those, 1 milligram in 250 for a 4 mic per ml drip, or 4 milligrams in 250 for a 16 mic per ml drip. We usually do 2 to 10 mics per minute, or 0.1 mic per kilo per minute. Again, you have to worry about caustic veins, so you want to make sure you've got a good dedicated line when we're doing a drip. So too fast, rhythms that get out of hand too fast. This is our algorithm for tachycardia with a pulse. So when we're talking about too fast, you're talking about rhythms that still maintain a pulse. Now the pulse may give out on you, it may get weak and thready, but for the most part, patient is still maintaining a pulse. And again, we're going through our steps, going through our what ifs. If you see this, you do that, and that's what our algorithm represents. As far as our medications, they're over there on the right-hand side in our boxes. With your tachycardia rhythms, they're usually classified into narrow complex or wide complex tachycardia. And what we're looking at with those is that QRS. And you can see on your screen there, wide QRS, narrow QRS, or normal. And that will dictate which road on the algorithm that we choose as far as our treatment parameters. It's typically heart rates greater than 150, and they're symptomatic. Again, your signs of symptoms may be acute altered mental status, they may be hypotensive, they may be experiencing chest pain. But we look at the QRS to be longer or shorter than 0.12 seconds when we're measuring out the width of the QRS. For a narrow complex, one thing we do while we're establishing our IV and getting everything together is we'll have the patient vagal. If you can kind of get them to hold their breath and bear down a little bit, it'll stimulate vagal response. Sometimes that will slow them down enough until we can get our medications prepared. Sometimes it doesn't work. Some of our physicians may come in and do a carotid massage to stimulate the vagal, just in an effort to get them slowed down a little bit. Our first line of drugs here is going to be adenosine, 6 milligrams IV push. We give that one very rapidly. We follow it with a 10 cc flush. If it's not effective, we can follow that with a double dose of adenosine, 12 milligrams IV push, again followed by that saline bolus. One thing with this adenosine, it is almost like reprogramming the electricity of the heart. If I took my computer right here and hit Control-Alt-Delete and restart it, that's kind of what I'm trying to do with my adenosine in an effort to reset that conduction pattern in the heart. If I don't get any results from my adenosine, usually we're trying to look at what the underlying rhythm is. In other words, when they get kicked up so fast, it's going to mask whatever the true rhythm is. A lot of times what we see when we slow folks down is an atrial fib or an atrial flutter. So if we can determine what the underlying rhythm is, then that will usually guide our next choice of drugs. Generally, we will go for a beta blocker or we'll go for a calcium channel blocker to help reduce their tachycardia. Beta blocker of choice here tends to be the low pressor. They'll order 5 milligrams IV over 5 minutes for up to 3 doses. The problem we see with that one is sometimes we run out of blood pressure before we run out of heart rate because it will significantly lower the blood pressure. If it's atrial fib or flutter that we see as the underlying rhythm, we tend to go a little bit more cardizem with that particular rhythm. If the patient becomes unstable, in other words, hemodynamically they're starting to sink, they're losing blood pressure, and we've tried drugs, then we're going to move to cardioversion. We're going to have to put them on our defibrillation pads, sync up their heart rate, and deliver some electricity to try to get them rebooted. Wide complex tachycardia, you kind of get a little bit of a choice here. You can choose adenosine if the pattern that you're seeing on your rhythm is monomorphic and regular. So mono means one, morphic means shape. The first rhythm that you see on the left there, that one is mono, one shape all the way across the screen, different than the second strip there, which would be considered polymorphic. So only if it's monomorphic and regular, we might trial the adenosine. But adenosine is really better used with narrow complex tachycardias. Better choice for our wide complex tachycardias is going to be amiodarone. 150 milligrams, we'll give that over about 10 minutes. And again, if the patient becomes unstable, then we'll have to move to cardioversion. Your adenosine, it does slow that conduction time through the AV node of the heart and interrupts those reentry pathways, again, kind of rebooting the electrical conduction. It is used for those heart rates greater than 150 and the patient is experiencing symptoms. Your dose initial, 6 milligrams IV, followed by a flush, and then a second dose if needed, 12 milligrams IV, followed again by a flush. Your pharmacodynamics, onset of action, it's very, very rapid. When we begin to push this one, we really do a lot of coaching with the patient because it puts them in asystole for a minute. So we're really watching the screen closely. Duration, it's very brief, almost as quick as we give it. They tend to pop right back up with their heart rhythm. Half-life elimination is less than 10 seconds. We have to be real cautious in any of our first-degree AV block or bundle branch blocks because, again, it can have too much effect and cause some VFib. And again, we don't use it with our polymorphic or wide complex tachycardias. Amiodarone, we're going to look at that one again when we get to our pulseless arrest because there's really 2 ways that we give it. We give it with a pulse, we also give it without a pulse, and I'll go into further detail with that one. So let's talk about pulseless arrest. In other words, I'm in a rhythm and I'm not pumping at all. I have no pulse. This is our pulseless arrest algorithm. So your patient is unresponsive and out. Again, biggest importance here is good quality BLS skills. It's not going to matter what drugs I'm choosing to push if we're not effectively compressing and pumping for the patient during their arrest. There are really kind of two roads to travel on this algorithm. Your left-hand side being your shockable rhythms, your right-hand side being your non-shockable rhythms. And again, depending on what our rhythm shows will dictate which drugs I move towards. Here are some different arrest rhythms that you may see. The shockable being your VFib and your VTAC. And you'll notice that when you're looking at that VTAC, it looks almost the same as what we just looked at with our wide complex tachycardia. So when you see that wide complex tachycardia, I always instruct our staff, you want to ask yourself two things. Is the patient alert and talking to me, and do they have a pulse? Because if they don't have a pulse, then we're on the shockable rhythm. If they do have a pulse, then we're on that tachycardia algorithm where we're going to try our drugs first. Our non-shockable rhythms are our asystole and our PEA. PEA is going to look just like a good normal sinus rhythm, good rhythm. You're going to think the patient's got a pulse. But if you see this, your patient's unresponsive, you want to make sure you're palpating for your pulse. Get your Doppler out and see if you hear your pulse, because it can trick you. So you want to make sure that in your pulseless arrest, compressions, all about those compressions, because it's not going to make a difference with our drugs if we're not getting compressions effectively. When we are giving our drugs, you want to be very systematic with how we give them. You want to be organized, so based on what we've given before and what we've seen as the pattern with our rhythms, start to prepare our drugs in advance. We want to only be prepared to stop compressions every 2 minutes and look to see what the rhythm is. And then when we give our meds, we're going to administer those during compressions. Because if I'm not circulating them, then my drugs aren't going anywhere. So our drugs during our pulseless arrest, again, oxygen. We want to make sure that we've starting the process for intubation or giving them AMBU bag mask device to get oxygen delivered. Our pressors that we're going to use, pretty much epinephrine's our mainstay of VTAC, VFibs, asystole, and PEA. You can give your epinephrine for either side of the algorithm. And then your antiarrhythmics, amiodarone, lidocaine, magnesium, or some other drugs that you might be given. Your oxygen, it does elevate your arterial oxygen tension. It'll help to improve your oxygenation. We give it for chest pains. If we think that the problem with our arrest is an oxygen problem, of course we're going to have our oxygen going. We're always using it during our arrest situations. Your epinephrine has alpha and beta receptor agonist. It can cause coronary perfusion pressure to increase as well as cerebral perfusion to increase. It'll help with the myocardial oxygen demand. It will help achieve ROSC. And ROSC just stands for return to spontaneous circulation. You got your pulse back. That's our whole goal in a cardiac arrest, is getting the patient's pulse reestablished, and epinephrine will certainly help us do that. We give it for VTAC and VFib. You do give it for asystole. You do give it for PEA. You do want to be cautious in the presence of an MI. If they are arresting, it is our mainstay, but it will increase that demand for myocardial oxygen. That's why either intubating your patient is important or making sure that we've got them on enough oxygen. We don't want to mix that one with alkaline solutions. Your dosage, 1 milligram, you can give it IV or IO. If we can't establish IV access, we can do IO. We typically will use a large needle on a drill in the intraosseous space. For IO, we typically will give it in the humeral head for our adult patients. It works great. Anything that I can give IV, I can give in an IO, and it's a great quick access especially for patients who don't have good veins at all. You can give epinephrine down the ET tube, but we do have to double our dose up to 2 to 2.5 milligrams diluted in the ET tube if we're having trouble getting access. We do repeat it every 3 to 5 minutes IV push throughout the code until we get our pulse back. Doses greater than 1 milligram at a time, unless we're doing ET tube, are not really recommended. In years past, we have done high dose epi as a last resort, but that kind of came off the table in 2005. We haven't done any high dose epi since then. If you're not getting anywhere with your code situation, then you do want to think about your antiarrhythmics. If you're seeing VTAC or VFib, We typically will start to give those after about the second or third shock. So if your rhythm is resistant and your shocks are not getting it converted, then you would move to your antiarrhythmic. Amiodarone is going to be your preferred one, again given for VTAC and VFib that's refractory. It's given also for those wide complex tachycardia. So if they have maintained their pulse, there's a very different way to give it versus without a pulse. So if they do have the pulse, that was the 150 milligrams that were given over 10 minutes. If we're giving it in our pulseless arrest, it's 300 milligrams IV push. So over time with a pulse, but as a push if we are pulseless. So we can give that first dose at 300. And if that doesn't work and we still have continued for 2 minutes and shocked and not getting any change with our rhythm, then we can give an additional 150. But our total bolus that we would give during our arrest would be no more than 450. If we get our patient's pulse back and we've used amiodarone, that's when we tend to start our protocol drip. So that's when we're typically contacting you guys to get our amiodarone protocol drip started. So after we've given that first bolus, then we move to that 360 milligrams over 6 hours, and then it continues for the 540 over the next 18 for 24-hour coverage. We can use lidocaine. Now I'll tell you that right now lidocaine you would not see on that algorithm for pulseless arrest for the adult for 2015. At the beginning of the guideline change in 2015, lidocaine did get onto the pediatric arrest algorithm, and it's a choice between amiodarone or lidocaine. And back about 9 months ago, American Heart did send out a new guideline that said the same choices that you have in pediatrics for amiodarone or lidocaine and pulseless arrest, you can also now add that to your adult. So when the 2020 guidelines come out, I do anticipate you'll see lidocaine printed on our algorithm just like we do for our peds. And those of you that have gone through cardiac drugs for a long time, you'll know that lidocaine years back was our mainstay before amiodarone. So it does suppress ventricular ectopy. You want to give it for the VTAC and VFib that do not respond to electrical therapy. You do want to think first about giving this if amiodarone is not available. We tend to still use the amiodarone as the more superior drug, but if it were not to be available, you could go with your lidocaine. It is 1 to 1.5 milligrams per kilogram IV, and then it can be repeated at 0.5 to 0.75 milligrams per kilogram. Total dose, max 3 milligrams per kilogram, and then we do an infusion of 1 to 4 milligrams a minute. Magnesium is also another drug that we will use a lot. It acts as a calcium channel blocker to decrease that ventricular rhythm. When we really use magnesium is if we see the torsades. So that polymorphic rhythm that we see, when we see that, we usually know that it goes hand in hand with a magnesium deficiency. Our patients that are potential for alcoholic withdrawal, they will go into torsades on us very, very quickly. So we usually try to keep magnesium where we can reach it pretty quick. And anything else where the patient may be associated with malnutrition, then you might see torsades. If they've got a lot of electrolyte imbalances, another potential for seeing torsades. We usually give 1 to 2 grams, either IV or IO, for the patients that we see the torsades. 1 to 2 grams if we know that there's a low magnesium. It is not on the ACLS algorithm, and we don't just routinely give it. You would have to have the indication of knowing that they were alcoholic or that potential for the malnutrition, or you would see the torsades. So we don't just automatically give any magnesium during our arrest. It has to have an indication. When we get to that other branch of our algorithm that was the non-shockable rhythm, asystole or PEA, really only 3 things to do. Good quality CPR, give our epinephrine every 3 to 5 as an IV push, and really if we can get to a reversible cause, that's going to be our best chance of success. So your epinephrine, again, 1 milligram IV or IO every 3 to 5 minutes, and think about your contributing factors. So why did the patient code? What made them code? That's what we look at. We've always had that divided into what we call our H's and T's. It's just an easy way to think through the common things that will make somebody go out on you. Hypovolemia, volume problem, either persistent vomiting or diarrhea, and it's got them volume depleted, or if it's traumatic, maybe like a GI bleed, we're losing blood or something. We're either going to replace fluids or replace blood. Hypoxia, we're going to give them oxygen, hydrogen ion, same thing as acidosis, we're going to give bicarb for that. If it's a potassium problem, we're going to be thinking through correcting the potassium. Hypoglycemia, we're going to make sure that we've checked their sugar, corrected that if needed. Hypothermia, if they are not warm, we're going to warm them up to reverse any hypothermia. Toxins, again, getting a good history from folks. What could they have gotten into? What was available to them? What can I potentially reverse? Most of the toxins that we see that cause an arrest are more of our narcotics, opioids, big heroin problem right now, so we give our Narcan for that. Get a lot of benzodiazepine overdoses. Otherwise, we're kind of at the mercy of poison control because we get folks that come in. If they can find it under the kitchen sink, then they will take it. Clorox, Pine Sol. I've got a whole long list that you probably wouldn't believe. But that's when we do contact poison control, and they will tell us what will potentially reverse whatever's been taken. Your tamponade or your pneumothorax, generally that goes along with our trauma. So we have to check to see, what kind of traumatic event the patient could be in. You can get a spontaneous cardiac tamponade just as a result from a myocarditis or an endocarditis, but we'd be looking to correct those as would a thrombosis. Calcium chloride, we also might use that one. Again, it's not one that's on our algorithm. It's not one we just routinely give. Only if we know that there is a calcium problem on board would we give that one. We may also give that one if we know that there's a potassium problem. Bicarb, we tend to give that one as well. In years past, bicarb was a drug that was listed on our algorithms, and it was routinely used because pretty much when somebody's been down for a while, they'll begin to get acidotic, and the bicarb will help to correct that, but it's not on the algorithms anymore. We generally will get an ABG and see where we are and then start to give the bicarb based on that. So your calcium chloride, it does increase cardiac contractility. It can help if we do have potassium problem. And we specifically would give it if we know that there's the indication. So if we know that they've had a calcium channel blocker and they're overdosed on that, you might give your calcium. Our dose is 8 to 16 milligrams of a 10% solution. You can repeat that in your 10-minute intervals. You do have to be cautious if they're presenting with bradycardia. If we give it too rapidly, it will cause bradycardia. Have to be cautious in patients that are on DIG. And it will precipitate in bicarb, so we have to be careful with our IV administration. If we've got bicarb that we're going to give, we would usually give it for those ventricular fibrillation rhythms. If we know that there's a potassium problem, if they're in a bicarb responsive state, if we know it's a tricyclic overdose, bicarb would be one of our reversal agents for that. If they've been in a long arrest and they're intubated, they're on a ventilator, then we would consider giving our bicarb as well, just to correct some of that acidosis. However, our priorities are always going to be to intubate, ventilate, defibrillate, give our epinephrine and our antiarrhythmics prior to trying to use our bicarb. It's 1 milliequivalent per kilogram that we give. We have to be precautious with worsened mixed venous acidosis from CO2 and retention. Metabolic alkalosis, you want to be very precautious when you're giving that, or with low potassium. If there's not really an indication, then we tend to not use it, but have to have a known state for this one as well. So as far as ED and pharmacy, a couple of little notes that I wanted to put out there. With our one chart system, when we have an arrest that comes in, they are on paper. So they typically do not do any of the resuscitation, any of the normal stuff that you see in the computer, which I know it's kind of which came first, chicken or the egg. We can't really get drugs from you until y'all have name, date, birthday, allergies. Those are must-haves. Sometimes we may not know that. So we kind of get to a problematic state. So what has been communicated to the ED as to the best of their ability, when they call you guys and ask for some medicines, at minimum, We should have patients' name, birthday, and allergies if we know them, and if we can, an estimated weight in kilograms. Now, if this is, somebody that's John Doe, we're kind of at a loss, so we might just call them John Doe and an unknown birthday. But to the best of their ability, that's the information that we've asked them to give you guys when we can. And again, at best, an estimated weight, because if they come in as an arrest, we don't always have time to get a weight as they come in. Now, once they are stabilized, they definitely should be putting those medications in one chart. So it may be a little bit retro that they're getting entered in, but when they do request meds, especially our titratable drips, you should see those being put into a computer at that point. They may get requested from you verbally by a phone call, but then retro get put in kind of as the patient settles down a little bit. But from a nursing standpoint, it will be on paper. Physician's standpoint, at the point that the patient is more stable, he will begin a note and put that into one chart. Typically what we will use is that titratable drips order set. So this is what they should be marking if they're requesting, your EpiDrip, Levophed drip, even your phenylephrine if we decided to go that route, dopamine. But this is what you should be seeing as coming across on the orders for any of the titratable drips. And then the amiodarone has its own plan. I've really asked them to pay close attention about unchecking that bolus, because a lot of times in the code we've already given the bolus and they'll forget to uncheck that, and then we've got medicine that we don't want to waste. So we will try to make sure that they uncheck that if that's not going to be given. Any questions about drugs? Any open dialogue we can have that I can take back to make it easier, better process? Because I know, like I said, it can be very problematic. I completely understand your end. Your hands are tied. You can't give me drugs because we're not in the computer. On our end, we may not have the luxury of putting them in a computer yet. So whatever processes y'all think that can help to improve that, we certainly want to take that back and use that to the advantage of making it the best situation that we can.
I think if you added that estimated weight to the list of things that they need to be able to at least give us on the phone.
Okay.
Because a lot of times we can enter a Levophed, as a
Right.
whole, but then we have to have a weight to put that rate into. Like
Okay.
they just have a starting rate. and
It literally won't let us enter
And it
anything
won't let us
until
do
we
that.
Okay.
So if they could at least have the estimated rate,
All right.
we could plug that in.
All right.
We do everything.
And generally, we kind of just eyeball. Usually at that beginning point, we're just kind of eyeballing. I know that it can be adjusted on the back end, but I'll make sure and let them know that y'all have to have that estimated weight.
And we wouldn't even have to put the weight into the actual computer part, because on the order itself,
Mm-hmm.
if you just gave me a verbal weight, I can plug it on that order.
Okay.
And it's not necessarily putting it in one chart as this is the weight.
Okay.
So that would help at least.
All right.
Kind of guesstimate.
We only have one place that we can put the weight, and it's collected during triage, and that's what populates in the Banner bar is the dose weight. So they have to go back retro and do that.
So did I understand it's a hard stop for pharmacy without a weight?
Yes, for the
Mhm.
titratable drips, it is.
Yep.
Yeah, we've gotten to more than a few situations where they've called and said, like, hey, we need this